In Module 5, we are going to talk about capacity management in healthcare systems and how systems engineering approach can help us to do that. By capacity management, we are mainly focusing on managing different type of resources that we have in the hospital. In a healthcare setting, there are several type of resources, and some of the most important ones are the beds that are available in the healthcare setting where basically patients are being treated, the nursing staff, and the operating room as well, the number of operating rooms that any healthcare setting have, and also the number of diagnostic equipments that we have, such as number of equipments for X-ray, for MRI, for mammography, and so forth. And so these are all different resources that healthcare settings have. And it's important for a healthcare unit, for a hospital, to know how many of each one of these resources they need to have and how they have to manage utilization of them. They want to monitor utilization of each one of these resources and make corresponding decisions if utilization is high or low. And as healthcare units try to make these decisions, the variability related to the number of patients that arrive at a healthcare setting to receive care and the variability associated to the type of care that they need and to the severity and intensity of the care that they need is going to make the decisions for managing these resources a lot harder. So more specifically, some of the challenges we have in healthcare system for managing capacity are as follows. One of them is that the healthcare systems usually have high fixed costs. Why? Because all the equipments that usually a hospital has, they are extremely expensive. The equipments that are available in operating rooms, the beds, and the facility itself. And so there is a high fixed cost to make a healthcare facility up and running, to have a healthcare facility up and running. And so it's not easy for us to just say our optimization model shows we have to increase number of operating rooms, or our optimization model shows we have to increase number of MRI machines or decrease number of MRI machines. So these are not some easily acceptable recommendations that we can have, because we cannot just say increase number of operating rooms by 2, because increasing the operating rooms, the number of operating rooms imposes a huge cost to the hospital or to the healthcare unit. And so those are not the type of decisions that we can easily implement. We have unknown and uncertain demand. Our demand is going up and down. The rate of arrival of the patients or customers to the healthcare unit is going up and down, and it's very uncertain, and it's really hard to predict the behavior of the arrival of the patients to the healthcare setting. That definitely makes the planning a lot harder. And also we have unknown and uncertain procedure times. So usually patients behave differently in response to the treatments, and also different healthcare teams also behave differently. So we may implement the same procedure or the same operation on a patient in an operating room, and the same setup on another patient may end up to be more complex, may take a lot longer, may involve some other doctors as well. So there is also a lot of uncertainty with respect to the treatments and to the procedures that are provided to the patients. Another challenge is related to the planning for the staff in a healthcare unit. So sometimes nurses need to be planned for working over shifts of 10 hours or 12 hours. On the other hand, the nurses that are working in operating rooms need to be planned to be scheduled for the block times that are specified in operating rooms. On the other hand, interns are going to rotate between different units, and we have to consider that in their schedule as well. So different personnel, different staff in the healthcare unit needs different setups for their planning. So, and that makes the whole management of the staff and of the capacity from that aspect a lot harder. And anyway, healthcare system is complex, and there's a lot of interdependencies. For example, there's a lot of interdependencies between emergency department and ICU, and there's sometimes a lot of the um, equipments are used between different departments. So and it's always hard to manage which department is using which one of the equipments to what percentage, and so forth. And that and all that complexity comes from the interdependency between the departments and all the relations they have, and they usually use, as I said, the same equipments. And difference in patient types, as we have talked about many times, we receive different type of patients to the healthcare unit. They come for different type of treatments. We don't know the severity of the treatments that each one of them need, and all of this add to the complexity of the planning. And finally, performance measures. For as we try to improve performance of the healthcare units, we are trying to look at different metrics. Sometimes we want to decrease, not sometimes, usually there are several metrics. We want to reduce mortality rate. We want to reduce the time spent at the healthcare unit. We want to increase the quality of care, increase the customer satisfaction. And as we try to plan for the resources to do the capacity management, we may need to take into account multiple metrics. Some of them need to be increased, some of them need to be decreased, and that also makes the planning again harder. So these are some characteristics of the healthcare units of the healthcare system, and these characteristics has made the planning for this healthcare system from every aspect a lot more complex. So among these four category that I mentioned here, the resources that we need to manage: beds, nursing staff, operating rooms, and diagnostic equipments. I'm going to start by talking about bed management. So managing inpatient beds, the beds at the hospital where the patients who end up staying at the hospital for several nights are going to use, managing those beds usually is one of the most important capacity management decisions that the hospital have to make. Usually the capacity of the hospitals, the number of beds that the hospitals have, is fixed. They cannot be changed easily. There is a rule, there is a regulation called Certificate of Need, CON. So Certificate of Need program is a regulation that most of the states in the US have adopted. I would say probably for sure 2/3 of the US have adopted this system. What happens in the Certificate of Need program is that it makes sure that there is a need in the community to more capacity before they let the hospitals to expand their capacity and to add beds to the hospital. Why they are so strict about this? Because if the hospitals just add beds and expand their capacity, as we said, this capacity expansion is going to be very, very expensive. So if the hospital just goes ahead and expand the capacity and spend a lot of money, however, that capacity is not going to be used, then what happens is that the fixed cost of the hospital is going to increase. And for the hospitals to make sure that their revenue or their income meets at least their fixed capacity, they're going to increase the cost that they're going to charge the patient for each bed. So if the hospitals have beds that are not going to be used by patients, the hospitals have no other way. The hospitals will definitely end up charging patients more to be able to meet those beds that have not been filled. And this Certificate of Need program is basically trying to prevent that. So the hospitals cannot expand their capacity, their number of beds, until they really have the need in the community. And then as we are talking about managing inpatient beds, we are basically talking about managing beds in four types of units, healthcare units. the intensive care units, ICU, the step-down unit, which is the level after ICU, the level of care that patients receive at the step-down units or telemetry units is less intensive than the ones that they receive at ICU. And then after telemetry units, if patients still need to stay in the hospital, but they don't need to receive an intensive care, they can go to medical, surgical, or med surg, or they also call it the floor. And also emergency department also has some specific number of beds, and we need to manage those as well. So these are usually inpatient units that have beds. And when we talk about managing inpatient beds, we are talking about managing beds in these units. So this chart shows just the relation between schematic relation between these units, and the fact that the patients move between these units, and our decision usually in this healthcare unit is not much of increasing number of beds in ICU or in the floor or in emergency department. It's not about increasing or decreasing number of beds, but it's more about when a patient has to go from one department to another. When do we have to discharge a patient to have some capacity release for other patients that are coming to the system? So it's more about the flow of the patients between these units, or the flow of the beds between these units. So here in this figure, we have emergency department. People come to the emergency department through walk-in or using ambulances. And then from emergency department, some of them would be discharged, but some of them will end up going to the ICU. And then in the inpatient care, patients stay at the ICU, or after some time they need to go to step down unit where they need less intense care, and then after some time they need to go to med surg unit or to the floor when the level of and the intensity of care that they receive is a lot less. And we also have some elective surgeries that needs to be done. Those are obviously not very severe, so those will end up staying at the step down units till they finally are ready to be discharged. And or we may have people coming from other health units that they may go to the floor or to the med surg unit when the level of care is less intense. And usually patients get discharged from the floor or from the step down units. Usually patients do not get discharged from ICU because this is where they need intensive care. And after ICU, if they don't need ICU, they either go to the telemetry unit, and then after that to the floor or to the med surg unit, and from there they can be discharged, but not directly from ICU. So in this setup, as we have mentioned, the key decisions in these setups is when to transform a patient from one unit to another, when to transform a patient from ICU to the step-down unit, from emergency department to the ICU, and so forth. And also when to discharge a patient so that we have some beds or some of those capacities set free and we can allocate them to other patients. And also another important decisions here is the time of the discharge as well. That has been proved to make a lot of change in the capacity of the hospitals to accept more patients as opposed to less patients. So these are the important decisions we usually need to make in a healthcare unit. And then when demand is unpredictable, when the arrival of the patients to a healthcare unit has a rate that is uncertain and is going up and down, then it's really hard to make sure that our beds have high utilizations, because at the end of the day, these are beds, these are spaces in the healthcare facility, and we want definitely to have high utilization for these beds. And we want them to be occupied, or the occupancy of the hospital to be high. However, the uncertainty associated to the to the rate of the customers or to the rate of the patients that we get in a hospital would make the planning harder and would make it harder to maintain a high level of utilizations for these beds. And when usually patients need a bed that is not available, that usually lead to the delay in admission of the patients who have an emergency situation. And these may lead to boarding when a patient has been treated in the emergency department and needs to be treated to the inpatient care, to the most of the time to ICU, but there's no bed available. And so these patients are going to be kept at the area in the emergency department before they can be finally transferred to an inpatient care unit, and that's the definition of boarding. When we need bed in the ICU or inpatient care and those beds are not available, then it can lead to boarding, and that basically means delay in transfer of the patients to the care unit, or delay in transfer of the patients between different wards, and also in scenarios when the patient really has an emergency situation, we may admit the patient to the ICU, to the operating room. And if that happens, then we have to cancel a lot of elective procedures that are not critical, but still the patient needs to do them. So we sometimes we may end up, because of the lack of capacity, we may end up cancel a lot of elective procedures, which would end up in the lack of satisfaction for those patients whose procedures have been canceled. So this is an example of the scenario where patients need to go from the emergency department to the ICUs. And let's assume the ICU has some specific number of beds. And when those number of beds are not enough, then we need to go through boarding. We need to still keep the patients at some area in the emergency department before the beds are available on the ICU. And the boarding actually is not a very pleasant thing to do, because it sometimes makes the condition of the patient to get worsened. And also it has been shown that boarding has increased the mortality rate as well. So boarding is something that we definitely want to escape, but sometimes there's no other way, and there's not many beds available in the ICU. So we have to keep the patients in the boarding unit. So as you can see in this system, what happens is that when patients are in the boarding units, basically they are waiting to finally go to ICU and get a bed. And so it's important for them to know what is happening in the boarding unit, how long the patients end up waiting in the boarding units, how many patients are waiting in the boarding units. And so these type of information are helpful for managers so that they can make decisions if they need to increase number of beds in the ICU, and by how many and how. So these are the type of decisions these are the type of information or analysis that we can do using queuing theory, or treating this healthcare setting as a queuing system. What do we mean by queuing system? Basically, queuing system are systems in which there is a queue. Let's say if you go to a bank to do some deposit, you have to wait in a queue if you want to do it in the bank. So that's a queuing system. If you call a call center to talk about why your internet is slow and so forth, you have to wait in the line before you talk to an agent finally. That's the queuing system. If you go to a restaurant and you are willing to have lunch or dinner, but the restaurant is full, you end up waiting for some time before you finally get seated. That restaurant is a queuing system. There is a queue and you are waiting in line. Even in manufacturing processes, when orders arrive or when their parts arrive to get processed on the machine, it's not that they can, after they are done on machine A, they can immediately get processed on machine B. If machine B is already busy with processing another machine, then these parts have to wait in a queue till finally machine B is ready, pick them up and starts processing them. So these are basically every system around us, or a lot of systems around us, fall under the category of queuing systems. And basically in the healthcare unit, a lot of the systems definitely have the characteristic of the queuing systems. As you can see in the ICU, definitely we have a specific number of beds, and here there are patients that need to go to the ICU, but if there is no bed, they end up waiting in a line. They end up waiting in a queue before they finally get a bed in the hospital. If we consider just the primary care, patients arrive, they need to be visited by the doctor, but they don't usually end up going to the doctor right away. They have to wait in a line, they have to sit in the waiting area, they have to wait in a line, and then their name is going to be finally called and they're going to be seen by the doctor. If you consider a pharmacy, the same. When you want to give your prescription to the pharmacy, or when you want to pick up your prescription, you don't necessarily go to the pharmacy and talk to a pharmacy, someone in the pharmacy right away. You usually end up waiting in a line till finally it's your turn, and you go then do what is needed to have your prescription ready. So basically, a lot of the parts in a healthcare system fall under this category and of a queuing system. And queuing systems are basically a type of system that have been analyzed in systems engineering. The theory that, or the techniques that we are using to model and to analyze queuing system is called queuing theory. So queuing theory is going to give us a set of analytical tools that we are going to use to model and to analyze and to improve queuing systems. Queuing theory is one of the tools that is covered under the umbrella of operations research, stochastic operations research. And if I can use queuing theory and if I can treat a healthcare unit as a queuing system, then I can answer a bunch of questions. Some of the questions that I can answer if I use the queuing theory to analyze the queuing system is that about the waiting time before the patient can finally get to a healthcare unit. So let's say the waiting time before a patient can finally get to the ICU, the waiting time in the line, in the queue, number of entities waiting in the line or in the queue. So now, for example, number of patients waiting on boarding unit before they finally can get to the ICU. We can also specify those as well. And those waiting times in boarding, waiting time in or the number of patients waiting before they finally get to the ICU or any other healthcare unit. These are valuable information that can be provided to managers till they finally, so they can finally do the analysis and know if we need to increase the capacity or not. We can also identify number of servers, which are number of beds, for example, in the ICU, or number of doctors we need to hire so that we can provide service to the patients faster, or number of technicians or number of staff we need to hire in a pharmacy to provide the service to the customer faster. So the number of servers also can be specified by using the queuing theory techniques. The utilization of the ICU beds, also we can specify that, and those are important because if we want to have any discussion related to expanding the capacity of ICU or any healthcare unit, definitely utilizations of the beds is one number we want to have from our system so that we can show that the utilization of those beds are high. That's why we have to increase the capacity. And then also we can also identify how these waiting times for the patients would change if we change number of beds in the healthcare setting. For example, in an ICU, how the waiting time till they finally get to the ICU would change, how the average number of patients that are waiting in the boarding unit would change if we increase or decrease number of ICU beds. We can identify those as well. And the same for other healthcare units. If we have a primary care, we can identify how long the waiting time of the patients in the waiting room would change if we increase or decrease number of primary care doctors. And also we can identify the utilization of the beds, and and this is usually can be done if using queuing theory. We can calculate the average number of beds that have been utilized. So if I divide number of beds that have been utilized by total number of beds, that's where I can calculate the utilization of these beds. And as I said, those are the numbers that are important for analyzing the performance and productivity of a healthcare unit. So as we are planning for the number of beds in the hospital, as I said, definitely we want to look at the utilization of those beds. And the utilizations of the beds in a healthcare unit is also called capacity level as well. And the certificate of need that I mentioned, it has been adopted by 2/3 of the states in the United States. Is the one that actually needs this utilization of data to finally let these hospitals, let these healthcare units to expand their capacity and add beds. And usually the minimum utilization that is needed is 85% for those beds. And once the hospitals or healthcare units can show that their beds have 85% utilization, then based on the certificate of need, they can receive the permission from the state to go ahead and add beds if and expand their capacity, add beds to either to the inpatient care or to the ICUs or the emergency department. And for example, the state of California does not have the certificate of need regulations. So the healthcare systems, the healthcare units here are not performing based on certificate of need regulations. So they end up expanding their capacity based on different routes. But generally in any healthcare unit, the higher the utilization of beds, the longer the waiting time is, and that's obviously very intuitive. The higher utilization, people will end up waiting longer for the patients to be finally discharged and a bed to be available. So a couple of things that we need to have in a healthcare, or a couple of assumptions we need to have to be able to analyze a healthcare system as a queuing system. One of them is that we want the rate of arrival of the patients to a healthcare system to be less than the rate of service or the rate of exit of the patients from that healthcare system. So to give you a simple example, let's assume we have a clinic and we have only one primary care doctor. And let's assume this primary care doctor can visit 4 patients per hour. Okay. And let's assume this clinic receives 6 patients per hour. So 6 patients per hour arrive, however, only 4 patients per hour leave on average. So over time, the number of patients that are going to get accumulated in this healthcare clinic is going to increase over time. And this number actually is going to go to infinity. So we call this type of queuing system as an unstable queuing system. And however, we don't, for the queuing system that we want to analyze, we don't want that to be the case. We want the rate of arrival of the patients to the healthcare system to be less than the rate of exit of the customer to the healthcare system. Let's to give you another example. Let's assume an inpatient care, just the med-surg unit, the floor, the one in which level of intensity of care provided to the customer, to the patients is less. Let's assume that to that unit that there we have only 2 beds. Each bed can provide service to 1 customer per day. So 1 customer occupies the bed, gets the treatment, gets what they need, and then they are done at the end of the day. So then I can say that these units would provide service to 2 customers per day. Each day provides service. Each bed provides service to 1 customer per day. So this bed provides service to 2 customers per day. And let's assume this unit receives 5 customers per day. So if the unit receives 5 customers per day, but provides service only to 2 customers per day, then 3 customers end up staying in the unit. And over time, the number of customers or the number of patients that end up staying in the unit is going to increase, and it's going to go to infinity. Again, I would call this system as an unstable queuing system. But for a stable queuing system, we always want the rate of arrival of the patients to the system to be less than the rate of the exit of the customers from the system. And usually the greater the variability of the time that the customer stays in the system, then it's usually harder to maintain a higher level of utilization for the beds in a healthcare setting. So if we want to consider or use the queuing system or queuing theory to analyze these healthcare units, to analyze the waiting times associated with patients before they finally can get access to a bed. If you want to analyze the number of patients that have to wait before they finally get access to a bed, if you want to know the utilizations of those beds and how those utilizations would change or how the waiting times would change if we change number of beds in the system, if you want to do all this analysis, then the only thing we need to do is to use queuing theory in healthcare settings, or in other words, treat a healthcare unit as a queuing system. To be able to do that, we need to make some assumptions. The first assumption would be that customers or patients that arrive to the system arrive one by one. They arrive one at a time. They don't arrive in groups. And that's not a very irrational assumption to make for a healthcare unit. And then the other one is that the arrival of these patients are independent from each other. The probability that the customer or the patient arrive to a system at a time has nothing to do with the probability of other people or other patients arriving to the system at the same time as well. These entities, these customers, these patients are independent from each other. Their arrival to the system are independent from each other. And then the third assumption is that the arrival of the customer, the rate of arrival of the customers to the system is not going to change over time. So it's not a function of time, does not depend on time. So that's also another assumptions that we are going to make to be able to apply queuing theory to the healthcare system. One type of queuing system in the queuing theory literature, one type of queuing system that has been defined and has been used extensively in different application areas is what we call as MMS. What type of queuing system here we are dealing with here? Here we are dealing with a queuing system that in which the customers arrive, they stay in one line. The time between arrival of customers has exponential distribution, and that's why I have letter M here for the first part. So the first character shows the inter-arrival time between the patients, the time between arrival of consecutive patients. And M means the time between arrival of consecutive patients has exponential distribution. And that's actually a valid assumption to make. These data have been collected and they have been graphed, and they have been shown that most of the time this data has exponential distribution. The other part, the second letter shows the distribution of the time it takes to provide service to a customer. If I'm talking about the beds in a ICU, this is the time that it takes for a customer to occupy a bed, or basically the time that the bed is occupied by a customer. If I'm talking about the doctors, if I'm talking about, for example, number of primary care doctors at a hospital, then this looks at the time that it takes for a doctor to provide service to the customer. So this is basically service time. This first one is inter-arrival time, the time between arrival of 2 consecutive customers. The second one but the second one is service time. And then the last one is number of servers in the system. And here server is a bed. So if you are talking about number of beds in ICU or emergency department, S is number of beds. And if I'm talking about number of primary care doctors in a clinic, then S is number of doctors that have to be available in a clinic to provide reasonable service to the customers. And then the other thing that I want to talk about is that queuing systems usually can provide either descriptive or prescriptive help to the analyst, to us as systems engineer. So these queuing systems can be used as either descriptively or prescriptively. And what do we mean by that? When we use a tool as a descriptive tool, and when we use an analytical tool as a descriptive tool, that tool is going to just help us to get a better understanding on what is going on in the system. If you guys are familiar with regression analysis and statistics, regression is a descriptive tool. When we perform the regression on some data, it just shows that how, for example, the overweight or obesity in a population depends on the food that people eat, the level of physical activity that people have, the social norms, and so forth. So in this example, we are trying to describe the weight of people as a function of the food system, urbanization, and other factors. So that's what we call as a descriptive system. A queuing system, either MMS or any type of queuing system, will have a descriptive role when we use the queuing system, and it's just going to tell us a little more about what is happening in the system. For example, in a care let's say healthcare unit, I may tell this queuing system that on average, I get about 14.8 patients per day, and on average, the length of a stay, LOS means length of a stay. The length of a stay of this patient in the unit of care is 2.9 days. And also I have 56 beds in this healthcare unit. So if we do the calculations in the queuing system, we may find out that in this system, there is only 4% chance that the patient arrives to the system and they do not need to wait, and they can immediately find a bed upon arrival. And so that's basically something descriptive about the system, that for a system with this arrival rate for the patients, with this length of stay of the patients in the care, and knowing that we have 56 beds, I can tell you there's 4% chance that when a patient arrives to the system, they can find a bed immediately, or there is an empty bed available immediately. So this is just something descriptive about the system. It's just going to help us to describe the system a little better. We also can use a queuing system as a prescriptive tool. And what does that mean when they're used as prescriptive tools? So a lot of optimization tools, linear optimization, nonlinear optimization, those are what we call as prescriptive tool, because they can prescribe the best solution for us. When you use a linear optimization to find the solution to something, that solution is optimum solution. That's the best solution. That's basically your prescription to go and do X, Y, Z. That's it. There's nothing else. So we can use queuing system as a prescriptive tool as well. For example, one scenario would be the situation in which we have the, let's say, rate of arrival of the patients to the system, we have their length of stay in the system, but we are going to play with different number of beds to see which one of them is going to give us a better probability that when a customer arrives to the system, they find a way, they find a bed right away. So in this queuing system here, we can see that, for example, with the specific rate of arrival of patients, with the length of stay of the patients in the system. And if I have 45 beds, then there is 66% chance that that when a patient comes to the system, they have to wait. They do not find a bed right away. If we increase number of patients, number of beds, obviously this probability is going down, is going to go to 2%. And here we can also try, but if I increase number of beds to 60, then we can see the probability that the patient needs to wait after they come to the system. They need to wait till they finally find a bed. That probability is going to go down with 1%. So, and if that's the probability that the hospital managers are looking for, that only there is 1% chance that the patient ends up waiting when they arrive to the hospital. If that's the level of service that the hospital managers want to maintain, then having 60 beds is the best thing that we can do to bring us to this chance that the patient end up waiting for a bed. And that's why we call it a prescriptive tool, because it's pretty much trying to find the optimum number of beds for us that can give us the desired number of the desired value for some of the performance metrics. So a queuing system can be used both as a prescriptive and as a descriptive method, given how, I mean, it just depends on how we are basically going to use it. So far we talk about queuing system, how and why queuing systems can represent what happens in the healthcare systems, and the fact that queuing theory is the technique and tools that can help us to analyze queuing systems and healthcare settings to be also one of the queuing systems, and the fact that an MMS system, queuing system, is the best type of healthcare, is the best type of queuing system to analyze any healthcare unit. And that refers to the scenario when arrival of the customer, the time between arrival of 2 consecutive customers to the healthcare unit has exponential distribution. The service time of the patients, the time that they occupy a bed, or if they are being visited by the patient, the time that they are being visited by the patient, that has exponential distribution as well. And we have S number of servers. These servers can be either number of beds that we are talking about in an ICU or in any healthcare unit, or this S if can be considered, for example, number of doctors as well. If you consider a doctor as a server, the S number of servers can be number of doctors as well. But the formulas that we have in queuing theory for MMS systems is going to help us answer all those questions that we talked about regarding queuing systems. How many patients are going to end up waiting till finally they get treated or they find a bed? What is the average number of patients that are going to be waiting till finally they get treated or they find a bed? What is the utilizations of the beds or utilizations of the doctor, and so forth. So these are all the questions that we can answer with queuing theory techniques. So what I want to do now is to give you guys the link to a couple of videos related to the queuing theory. This will be 3 videos. The first one gives you some introduction to queuing theory, and it tells you basically what are some of the data that we need to be able to analyze the queuing system. That's the first one. The second one is going to tell you how we did the calculations to find out the number of people waiting, the length of the queue waiting, the time that they are waiting in the queue, and so forth. The formulations that we calculated these measures in a simple queuing system, and that simple queuing system would be MM1 when we have only 1 server. And then the third video will be the scenario that is going to tell you how we develop the formulas on an MMS system when we have S servers. So I want you guys to watch these videos. If you already have had queuing theory in your operations research class. So these videos are going to help you just refresh your mind with respect to those formulas. If you haven't had queuing theory in the past, these videos are good to teach you these new concepts and these new techniques. And then in the next session, I'm going to talk about more application of queuing techniques in hospital system and provide examples to you guys so that we can solve them and learn better how queuing systems can be used to analyze the beds or the staff capacity in a hospital setting.